All right, welcome back everyone to another virtual shadowing session at Hearts for Health. It has been a while. I think we haven't had a session for a while now for the whole month of April, but we are back. We'll have two more sessions today and on Thursday. That's going to wrap it up for our spring semester, and we'll be back for more sessions in June. I will recap on those details, but I know that we had a few questions regarding that. So I just wanted to address them off the bat. But today we're joined by Raja. He is a fellow in surgical oncology at Harvard Medical School. He'll be talking about the specialty a little more, his personal journey. I do have reminders for those who are new. Specifically, this is probably old news for those who've joined in the past, but we do have Q&As at the very end of these sessions. So if you have any questions for Raja, please feel free to type them in the chat as we go through at any point in time. And then the last 10 to 20 minutes we'll save at the very end of this hour for that Q&A. I'll be reading out the questions in the order that we receive them. And then the second thing I want to point out is that we do have a listserv and an Instagram page. Most of y'all have probably heard of us through our flyers on our Instagram page, but we also do have a listserv. That listserv does include a few other opportunities that are more frequently posted because we do have a couple programs outside of just shadowing. We do have a mentorship program. We do have a volunteering program. Well, a couple of volunteering programs actually, and those open up from time to time at the beginning of each semester. We're going to have our next cycle in the fall, in August. So if you want to hop onto that email listserv, the way that you can go about that is either email us at shadowing.h4h@gmail.com, or really any of our emails. We do have a couple emails around the team, or you can hop onto our website. At the very bottom, we have a subscription form. If you put your name, your email, you'll be good to go and add it onto our listserv. Again, just a few reminders. If anyone has any questions, feel free to email us. But I don't want to take up too much time, so Raja, feel free to take it away.
All right. Thank you, Michael, for that kind introduction and for inviting me to be here today. It's a pleasure to chat with you guys about my experience and my journey getting here. So I'm Dr. Raja Narayan. I'm one of the surgical oncology fellows at Harvard Medical School. I work between the Dana-Farber Cancer Institute, the Mass General Hospital, and Brigham and Women's Hospital. And as part of my training, I completed my general surgery residency at Stanford. This is a talk that I gave at a point during my residency that I've updated with a couple cases that I've seen since that time. So I'm going to kind of go through this and explain kind of the life in a day for a surgery resident and fellow, go through a couple cases for you guys. And then I'll talk about some high yield pearls that folks should be aware of if they're applying into medical school. I'm happy to take questions at the end. All right. So this is kind of my outline for what I just mentioned as well, so what we're going to talk about. And so this is a picture of Stanford Hospital where I primarily worked as a resident. And as part of your residency training, there are programs where you're able to work at a single hospital, and there are opportunities to work at multiple hospitals at certain programs. So I worked at the VA, the Veterans Affairs Hospital in Palo Alto, Kaiser Permanente, to get a private practice community experience as well as part of my Stanford residency. This is a picture of the Lucille Packard Children's Hospital as well to get a pediatric surgical experience, as well as the Santa Clara Valley Medical Center, which is a high volume burn and trauma center, or a county hospital, which is a safety net hospital that sees patients that otherwise don't have access to insurance. So as part of my training, we're not just at one hospital at Stanford, we get the experience of working in a variety of centers to get a flavor of medicine where people see it in different avenues. So I'm going to focus on an experience in the day of working as the trauma chief resident at the Santa Clara Valley Medical Center and transition into a couple cases from there. So the day-to-day for me would usually involve waking up at 5, getting ready for work, and I usually am at work by 6 o'clock where we have morning sign out. So as part of our morning sign out, we have the entire team there. That includes junior and senior surgical residents, attendings, medical students as well, and volunteers at times that go through updates of the existing patients that we've had on the service for things that happened overnight. And we discuss any new patients that were admitted overnight as well that may need surgical management during the daytime. And so we talk about these, answer any questions that may have arisen overnight that were not answerable, and discuss details of what need to be accomplished during the day to progress their care forward. So once we accomplish our sign out here, we then go for rounds, which is one of the fun parts of the day, but as is sort of the stereotype amongst surgeons and surgery residents, our rounds are relatively quick. I've listed an hour and a half here, but we generally are a little bit quicker than that. where we go about and see patients wherever they may be in the hospital. And so I've got a mishmash of photos here from when I've rounded as the surgical ICU chief resident on the left side here, and on the right side when we were on transplant surgery, and we would pull up Doppler ultrasounds for transplanted livers to see how the arteries were doing. And so this is an opportunity for discovery where you're seeing patients to get physical exam findings that will inform what changes you may employ for their care for the rest of the day. You've also got imaging that's completed, like the liver Doppler ultrasound that I've shown here, or a chest X-ray or an abdominal X-ray that may inform new things that need to be done that may not be in the trajectory of what you had planned for this patient. And we quickly squeak in through rounds really early in the morning, unfortunately, often waking up patients to see them so we can get an idea of how they're doing before we're off to the OR for essentially most of the remainder of the day. And then after that, we're in the OR and we're kind of secluded there with small opportunities to kind of poke out and see patients in between cases. But this, for surgeons and surgery residents, are the most fun part of the day. And here are pictures of some of my colleagues and I working in the OR. This is myself scrubbed in with the glove on the left side. And this is one of my friends who's one of the anesthesiologists when I was the chief resident on the pediatric surgical service. He was also a medical school friend of mine that we trained together at UC Irvine, where I was a medical student, and just happened to become an attending surgeon or an attending anesthesiologist at Lucile Packard Children's, which just kind of goes to show you that the medical community becomes smaller and smaller as you go further along in your training. And this is a photo also at Lucile Packard where I was taking care of one of the smallest patients that I had the opportunity to operate on. And I actually still get Christmas cards from this family for this patient who's now 4 years old. And here's another photo when I was working at Stanford Main Hospital after we had done an oncology or a cancer case. And you can see here that the attending surgeon is not scrubbed in because they often will let us start the operation if we've demonstrated that we have the technical skill and safety in operating that we can begin the operation without any issue. And then they will join us for the more complex portions of the operation, usually just a few minutes or half an hour in. And as well as our surgical tech who's in the green glasses. So it's not just surgeons that are operating by themselves. We often have a surgical scrub tech that's there with us, who's in charge of making sure they give us the instruments so that we can work expeditiously without having to stop the operation and look elsewhere to find an instrument to use for what could be a hazardous situation of bleeding or dissection that we can't really break eye contact from. So it's a key member, they're a key member of our team that we really can't function without, and is often an uncelebrated member that I think is very important for folks to know about. And then here's an example of me operating and doing laparoscopic surgery, where I'll show you an example of this for a later case, where we're using sort of keyhole incisions on the patient to insert a camera, which you can see, I don't know if you can see my cursor here hovering around this white light cord that's entering into the patient to illuminate an otherwise dark abdomen. And I'm holding with my two hands two small laparoscopic instruments that essentially are the width of a small pencil, but extend deep into the abdomen. And we're looking at a monitor that's showing what the camera sees in the abdomen to help maneuver and do this operation without a single long incision. And this is for the purpose of minimizing postoperative pain for patients and has enabled many patients that undergo surgery for cancers of the colon, the rectum, issues with the gallbladder or spleen or liver to go home much sooner than they would have otherwise with an open single incision approach. And here are a couple of other examples on the trauma service where we have the opportunity to work with some of our colleagues as well with a supervising attending, and then in trauma as well, which can be somewhat of a busier, bloodier service, which I've given half of the picture here for. So, we're in the operating room and we're taking a break at the end of the day after we're done operating, and suddenly we have a major trauma alert. So here's our first case that we're going to go into. And so you hear an overhead beep that there's a major trauma coming into the hospital. And so wherever you as the senior trauma surgery resident needs to come down to the emergency bay. And this is what you find there, where you have a constellation of team members that are there, ranging from nurses to ER techs to junior residents, as well as your faculty attending or your attending trauma surgeon that's there to back you up for this case. And so we have folks that are there documenting. You have folks that are there dressed in gowns to help perform procedures, place IVs, or even leads on the patient so you can get some data on them as soon as they arrive. And you get very little information about the patient when they're arriving. And I remember for this case in particular, you only get the age, 17 years old, and then they tell you what was the mechanism of their trauma, which we split into two mechanisms, are either blunt trauma, which is a car accident where someone got hit by a car, or were in a bike accident, they fell off of a bike, or penetrating trauma, which can include someone has either been stabbed or shot. And this was a young man, 17 years old, that had been shot. So, or 19 years old. So when they arrived, the story from the emergency medical team informed us that this is a 19-year-old male that was found down in the field. Unclear how long he had been there. When they found him, he had 7 bullet holes, and there was a lot of bleeding found around him. In the field, they were able to get a blood pressure, so that indicates to us that there were signs of life when they found him. 90/60, which is very low for a gentleman of his age, and his heart rate was 120, which is fairly high for what we would consider normal, which is generally between 60 to 90 or even 100. And this last value I've given you here, the GCS, that's sort of a way that we measure someone's neurologic status. So we tell how their motor functioning is working, whether they're able to follow commands and do things that we ask them to, like opening their eyes, whether they're able to talk, and how their eyes are functioning. Are they opening their eyes in a spontaneous way, like a normal person would be talking, or are they completely closed and unresponsive? And when you have a GCS score of 3, that is the lowest score that you can obtain, which means that their eyes aren't opening, they're not making any verbal noise, and they're not displaying any motor function, all of which are very concerning for this sort of a mechanism of a trauma. So when he arrives, despite us getting vital signs in the field, no pulse is detected, which is immediately, obviously, a very concerning finding. But we know that he had signs of life within 10 minutes of being in the emergency room. And so the next thing that kicks in is our algorithm that we have all ingrained into us when we're training as a junior surgery resident, where we're trying to do what's called the ATLS, or the Advanced Trauma Life Support System. And this is just like the alphabet, where we think in our head A, B, C, D, E, and we're going through and determining what are the things that need to be appropriately functioning to make sure that this young man can sustain this injury and survive. And we go through things to make sure that we are addressing them in a sort of stochastic fashion. So A, we think of airway. Are they opening their mouth and able to have air enter? Because if they don't have a patent or an open airway, they cannot breathe. We also include whether their cerebral spine or their neck seems to be in alignment, because if there was an injury where they had fallen and they had snapped their neck, there's not going to be any sense in improving their breathing if they don't have any functioning neurologic activity below the neck. But fortunately, with the mechanism of this gentleman, there were no gunshots near the neck. So his airway seemed to be secure. There was nothing obstructing his airway. In terms of breathing, we could actually hear that he was breathing in both sides on his lungs. But C is kind of where we had an issue, where his blood pressure was 0. And his heart rate was 0, basically. And so we were concerned at that point that he was not perfusing or he was not passing blood where he needed to. And so the next step for this was to determine how we can restore vital signs for this gentleman. And this is one of these rare scenarios where we're able to proceed with what's called an emergency resuscitative thoracotomy. So I've kind of demonstrated here another algorithm that we think of that's ingrained in us to immediately act upon, where we ask, as I alluded to earlier, are there any signs of life? And if the answer is no, then you have to ask yourself a couple of questions of how quickly this gentleman had arrived to us. Was this blunt trauma, which means that, is it possible that he got thrust so hard that his heart stopped working, in which case a thoracotomy, which I'll explain in a second, would not be helpful to restore vital signs? Or was this penetrating trauma, which is the scenario at the very bottom left-hand corner of this box, which is the ideal scenario to perform an emergency thoracotomy, where the patient likely has a sharp injury to one of the main greater vessels within the chest, that if we were to identify and repair in that instant, you would have an opportunity to save this gentleman's life. And so that is what we proceeded with in this scenario, given the number of gunshot wounds that he had sustained, and just the trajectory of where the bullet holes were made us concerned that one of them had probably passed through a major vessel, either in the chest or potentially in the abdomen, causing him to bleed out. So in this scenario, we perform an incision that's just below the nipple, down along the rib, until you essentially reach the bed. So that way you can splay open the chest wall and enter into the cavity where you can find the heart. And when you find the heart, there are two options. One is you determine whether the heart is unable to beat because there's blood filling around the heart in a space called the pericardium. For him, that was not the case. Or if that is not the situation, then you need to figure out where the bleeding is from elsewhere. And if it doesn't appear to be in the chest at this time, because we've passed through in the domain of where the lung is situated, and there's no extensive bleeding that's arisen from entering through the pleural cavity or the lung cavity, and there's no bleeding in the pericardium, that makes us think then that there must be bleeding that's below the chest or in the abdomen, or even in the legs that could be accounting for the volume of blood loss. So in order to act here, what we need to do is prevent further blood loss into the abdomen by clamping the aorta, which is what this clamp is demonstrated here. And that's exactly what we did for this gentleman. We clamped the aorta, and at the same time as all of this was happening while I was doing this procedure, Our ER nurses were setting up IVs and getting blood into the gentleman. And soon after, they were able to get a couple of units of blood transfused, and we got control of the thoracic aorta. Lo and behold, his vital signs had improved, and we were able to get a blood pressure and a pulse from him. So he had regained signs of life. And at that point, we had stabilized the patient enough to go to the operating room. This is a similar setup for how patients are set up for a trauma in order for an operation to explore the abdomen to figure out where they're bleeding from. In this exact scenario, where there seems to be a tremendous amount of blood loss into the abdomen that could have caused them to lose their vital signs. So we make a midline laparotomy incision to enter the abdomen to explore. And from his gunshot wounds that were all predominantly at the level of the nipples or below in his abdomen, we found that he had a GSW, or a gunshot wound, involving his left liver, the hepatic vein, the portal vein, which is another vein that enters into the liver, near his gallbladder, which necessitated us to remove his gallbladder, as well as shattering his entire right kidney, which required us to remove his right kidney in its entirety. Then below the abdomen, he also had an injury to the superficial femoral artery that we called in our colleagues from vascular surgery to work on at the same time as we were exploring the abdomen in all four quadrants. But these were the main injuries that he had. And as we were repairing these and getting control, the anesthesiologists that were working with us were making sure that he got enough transfusions to restore the circulation or the volume of blood in his system that he had lost from this injury. So they were successful and we were successful in doing so. So he was able to come out of the operating room. He went to the ICU, intubated, meaning there was a tube in his mouth breathing for him while he was still relatively unconscious, as he had received general anesthesia for quite a long time for this operation. But within the next 5 days, so POD means post-operative day, between post-operative day 0, or the day of surgery, to post-operative day 5, we were able to wean him off the ventilator and eventually extubate him. And over the next 60 days, essentially, we were able to slow the volume of transfusions he needed, because the bleeding that we had controlled in the operating room that had transitioned into a slow ooze from the surgical resection places had slowed down. He had some antibiotics that were on board for a couple of infections that actually occurred following his injury, and slowly had to regain the ability to eat again, the ability to walk again, move his bowels and go to the bathroom, for number one. He was able to achieve this over time and actually was able to be discharged directly home, rather than what we had thought would be the most likely outcome of going to a rehab center first, because he had been with us for such a long period of time and we had made sure that he got physical therapy while he was there in the hospital. So this is sort of an unusual and tremendous save for a gentleman who was fine with us sharing his story here, that demonstrates sort of some of the quick thinking that we have to employ in a trauma scenario. That's taught to us very early on. That's part of our usual algorithm as we go through our ABCDEs to figure out what are the problems that we need to address and what are the procedures we need to employ right away to act on if we see that there's an issue that needs to be resolved before we move on to the next letter. All right, so I'll move on to my next case, and I'm happy to take any questions about this initial case at the end as well. But for our next case, I'm shifting over to what I'm doing primarily now, where I'm studying and working as a surgical oncology fellow here in the Boston area, regarding a 58-year-old gentleman that was a IT worker, an information technology worker, that had a history of leukemia, that had received chemotherapy and was in remission or had no evidence of his cancer for about 10 months before presenting to a local hospital where he had what's called neurologic decline, meaning that his central nervous system and his peripheral nervous system together were not functioning as normally as he had recalled. So 3 weeks prior to his presentation, he was having difficulty with fine motor movement, meaning he wasn't really able to use his mobile phone. He wasn't able to hit like on his Hearts for Health app or profile on Instagram. And he was having other issues that were very mainly related to his work, which was very concerning for him. He made it to a local hospital that was evaluating him, and they weren't really sure what was going on, but suspected at the time that this may have been related to his leukemia in the past. And so he was transferred to Stanford after he started developing new issues such as dysarthria, which we have to go back to your Greek on how to dissect words. Dys means a problem, and arthria is how you pronounce or you say words. So he was having issues with pronouncing and saying normal words, which was obviously concerning to him and was very odd for us. He was admitted to the medical oncology service that was very familiar with him. Leukemia is a type of cancer that is not treated or cured with a surgery. It's treated with chemotherapy, and they had followed him in the past and taken care of this issue before with his chemotherapy regimen, and were perplexed that he was having this issue now. And then they performed an extensive neurologic workup to see if there were other issues that could be causing this problem. And some things that could be related to this would be a viral cause. There are certain viral infections that you can receive that can cause a temporary dysfunctioning of your neurologic system. That was not the case. And they tried steroids for him because sometimes if there seems to be an inflammatory issue that's causing a problem with your central or your peripheral nervous system, the use of steroids can sometimes blunt the effect of the immune system that perpetuates these inflammatory reactions that start causing problems in your neurologic system. And there was a small improvement that they noticed, but really nothing that changed the trajectory of his decline. And at that point, they decided to proceed with some imaging. So they got what was called an FDG PET scan, which many of you have probably heard as a PET scan. We always try to emphasize in this prefix for PET scan what type of a PET scan it is. FDG means fluorodeoxyglucose PET scan, which means fluoro, which means fluorescent like a light. Deoxy, as you might recall from chemistry, means that you are taking a oxygen molecule off. And so this is a variant of a glucose molecule that's missing a OH or a hydroxyl group, which then renders it capable of lighting up on this specific scan when you introduce a certain dye into their system. So this is an FDG PET scan that I'm about to show you. And what it revealed was high metabolic activity, or what we call avidity, in the spleen, which is odd because the only time you see high metabolic activity or high uptake of glucose is either in an organ that is known to be functioning very rapidly and strongly, like the heart, or in cancer, because that's an abnormal uptake of energy to cause something to grow preferentially versus, the rest of the body. And so it showed uptake in the spleen of all places, which was concerning for a term that's called malignant transformation, meaning their CLL or their type of leukemia had evolved into a new version called lymphoma, which is not a type of cancer that's spread through the bloodstream, but now you have a concrete mass that's causing their singular cancer that has the potential to spread and metastasize and cause other problems. So here's this image of the FDG PET scan. Here again, as I alluded to, is the heart that appropriately and usually does take up more metabolic activity just because it's a very demanding organ and takes up a lot of glucose to function appropriately. But here in the left upper part of the abdomen is the spleen that seems to have a pole that's lighting up as if it were part of the heart, but it's separate. And this is very unusual to see on the spleen for a normal PET scan if we were to scan yourself or someone else in the crowd. And you can see in comparison, here's the liver, which is a large organ that functions constantly to maintain a balance of glucose levels and hormones in your body, that's not lighting up as intensely as you see here, which made us concerned that there was something abnormal going on for this patient. And so we were consulted because of the fact that the spleen had this avid mass that was there, and asked to remove the spleen because they were concerned that the patient had developed what is called a paraneoplastic syndrome, which I'll explain in the next slide. We evaluated him in the morning and we found some of the same issues that I mentioned earlier. And we were kind of concerned about this and confused because it's not a common thing that we see on this survey. So we came back to see him in the afternoon to figure out how he had changed during the day, just 12 hours. And in the afternoon, he wasn't able to speak at all anymore. He wasn't even following directions when we asked him to give us a thumbs up or a peace sign. And in fact, couldn't even get out of bed anymore. And this was a dramatic change that was still part of his decline that he had been going through for the last couple of weeks. And so that made us worry that if we weren't going to do something, what was going to be the next step in his decline? Would it be that he can't open his eyes anymore, can't open his mouth, can't breathe anymore because the diaphragm, which is the major muscle that enables your lungs to fill with air and oxygen, stops functioning? If all of those would be the case, he would need to be intubated, meaning a tube would mechanically help him breathe. And if that were not to be reversed, he would need a tracheostomy, which means you would have a permanent tube in your neck that would breathe for you, that can, in rare circumstances, be removed eventually if the patient is able to breathe on their own again. But with what evidence we had of him going further and further downhill, there is nothing for us to believe that what we've done so far would allow him to improve, which made us very concerned that whatever was going on in the spleen that we couldn't really explain at this point was the culprit for this issue. So I mentioned a term earlier called a paraneoplastic syndrome. So this is a very rare, a very odd circumstance where you have a certain type of tumor. And this is one of our medical students at the time that was working with us, made this wonderful diagram and shared with us, where you have a B cell, which is a very normal immune cell that you have that makes antibodies to fight things like bacterial infections, viral infections that you may have, can sometimes have an abnormal mutation that causes it to convert into a type of cancer, like a leukemia. And that's exactly what this patient had. This was chronic lymphogenous leukemia. And this was treated and essentially cured to the extent of the knowledge of the medical oncologist when checked on blood tests thereafter due to chemotherapy. And he was in remission, as I mentioned, without any evidence of cancer for 10 months. But now the theory was he had undergone a change, which they termed Richter's transformation, that one of these lingering cells that were present in a microscopic fashion was able to have some type of gene alteration that allowed it to switch from dividing itself and going into what's called a non-clonal version, meaning that there's different versions of each cell. So it's not like clones that are making themselves one after the other, which is actually a very sensitive type of leukemia that can respond with chemotherapy, to a clonal transformation, which means there's one preferentially strong cell that has an abnormal variation in a gene that keeps duplicating itself over and over again. And these are very resistant to chemotherapy and unfortunately have very poor survival if left alone, and can be the cause of paraneoplastic syndromes, which in this case means these cells, which are sort of the children of this original B cell, can form antibodies that attack these neurons. You can see here's an example of a neuron with a nucleus, and you have this dendritic arm here, and you've got these myelin sheets that are supposed to correctly function and send neural impulses down from up to down. But when you have these antibodies attacking, it disrupts that pathway. And that is what our medical oncology colleagues thought was going on with this patient in particular, because of this mass that seems to have grown within the spleen. We weren't certain of that. And so the next question was, what do we do in this scenario? So the next step was we can continue with steroids and attempt to initiate chemotherapy. It's a valid option, but the problem is he only had minimal response before. And if he had no improvement with the degree of decline he had achieved thus far, we would have the risk of motor failure that would lead to respiratory failure and intubation, like I had mentioned. All right, well, what if we look for another source and figure out if we can exactly determine the type of mutation that happened and figure out if there's a specific type of chemotherapy we can differently give to this patient? The problem is this isn't a treatment to do a bone marrow biopsy to get that information, and you're delaying time. And again, you would have that risk of respiratory failure and intubation as well. And then the other option is, okay, well, we know only one part of the spleen is at an issue. So why don't we just take out half the spleen? And I can tell you from personal experience, this is not a good option. The spleen is one of those organs that does not have what I would call segmental anatomy, meaning it's not split in half, split in quarters or thirds. Instead, it's just got a certain sort of capsular anatomy that if you were to cut into in any fashion, it will bleed like crazy until you remove all of the blood flow to that organ. So a partial splenectomy, although theoretically possible, is very unsafe and has a very high risk of bleeding. And then lastly is a total splenectomy, which is not a term we commonly use. We just say splenectomy because I would say 99% of the time, if you're operating on the spleen, you're doing a splenectomy. You're never doing a partial splenectomy. So that's what we decided to do in this scenario after weighing the risks and benefits and talking with his family to help consent him for this procedure, because at this point, unfortunately, he was not able to consent himself. So we proceeded with a laparoscopic splenectomy. And so these are some pictures that demonstrate how we set this patient up. He's flat on the table, and we've got these 4 ports that we designated as how we're going to enter the abdomen. We have a port here that we introduce our camera. And then we also insufflate the abdomen, which means that we include air, mostly carbon dioxide, into the abdominal space that allows the abdomen to go from flat to wide open. That allows us to maneuver in the abdomen as all of the organs are towards the floor, and the abdominal wall becomes a ceiling that's tented up for us so we can maneuver in there. So once we have the camera in, it allows us to see where there are blood vessels on the abdominal wall. We intentionally avoid those blood vessels so we can then create additional ports that allow us to put a left and right hand in, as well as an assistance hand to help retract the spleen or other organs out of the way, as the surgeon is able to use the camera and another arm or 2 arms, however they prefer to operate in this scenario, to help dissect the spleen off of the regional anatomy. Here are a couple of other images of the anatomy that we're dealing with. Here's the spleen right here as it's situated in a normal person. This has several attachments. So it's attached to the stomach, and there are often small arteries that are going from the splenic artery here and the splenic vein to the stomach. And so these need to be divided in a way that makes sure that you have what's called hemostasis or no bleeding. Then you have the attachments to the abdominal wall. And so these are usually avascular, meaning there are no blood vessels in there. So you can divide these either with scissors or with what's called electrocautery, which is honestly a fancy term for a lightsaber. We have a type of a device that can burn tissue as you're working your way along. And so that's what we commonly use to divide across here. And we suspect that there can be small blood vessels, but not, named blood vessels, like as I mentioned here. And then once we've kind of gone this way, I'm going clockwise to show you what other attachments there are. There's also the splenocolic ligament, as you can see here. So you need to drop the colon. This is the left colon. And this angle right here is known as the splenic flexure, which means your transverse colon is coming here, kind of hits the spleen, and then it flexes downward to become the descending colon. And there are some avascular attachments here that we need to divide. So we're going around clockwise again. Behind this is the kidney. It's not really well shown in this image here, but there are some attachments between the spleen and the kidney that need to be taken down too. And often the main blood vessels going into the spleen, which include the splenic artery that's on top and the splenic vein that's below, courses through the pancreas that you can see here. And you don't want to divide the pancreas because this has a strong proclivity to leak pancreatic enzyme, which is the component of what you would digest food. And so if you were to leak pancreatic enzymes into your abdominal cavity, that would start digesting the abdominal organs and the abdominal fat. And so we have to be very meticulous in making sure that the final thing that we divide here is just the splenic artery and just the splenic vein and does not include the pancreas in those bites. So here's a picture of how we're kind of negotiating our way through, where we have, as I mentioned, those small instruments like laparoscopic scissors to try and cut these avascular attachments between the colon and the spleen, as well as the abdominal wall and the spleen. And we do the same with the attachment to the kidney. We use a different device to divide the attachments here because we know that there are big blood vessels there. And then when we're at the end here, as I can show you, we use a stapler to divide the main vessels that go to the spleen, because these are sort of the more secure versions of instruments that we can use to divide big blood vessels, whereas the electrocautery or lightsaber stick I'd mentioned earlier functions well for blood vessels that are less than 7 millimeters, really, which we don't count or measure when we're doing the surgery. We just visually are able to kind of perceive what they look like. But this is usually the last sort of step here that we were to divide it. And then we fit the spleen into a small bag, which then you have a couple of options of how to remove it. This bag is also introduced into the abdomen through a small port. And then you can either take the spleen and just morselize it up, chomp it up so you can take it out in small pieces in the bag so none of it spills into the abdominal cavity. And that's usually when you're doing this operation for a big spleen for reasons that are not related to cancer. You can imagine that if you're going to chomp up a spleen that's bearing cancer, who knows if there's a little bit of it that can spill out, and heaven forbid, spill into the abdominal cavity, and then you have recurrence or relapse of your cancer, which we did not want to risk. So in this scenario, we create a slightly longer incision and we remove the spleen as one piece, and that's what it looked like. So here's the spleen, and you can see this very odd protrusion right here that's on the bottom right-hand side, which was suspicious for this tumor. So how did he do after that? Well, on the first day, he was extubated, and finally he was talking the same day as his operation, which he was not able to do that morning. Then the day after, he was actually following directions and even walking. And over the next week, while they were slowly monitoring his recovery, he was able to regain functions of eating, moving his bowels, and even had complete recovery of all his hematologic laboratory markers as well. And essentially was a normal walking, talking human being again before he left the hospital, which was just a profoundly interesting case and was the reason why we reported this as a case report that's now been published. And the pathology report came back indeed with what I mentioned earlier, that his CLL had converted through Richter's transformation into diffuse large B-cell lymphoma, in fact. And so this was exactly the right move. But at the time, we didn't have all the information. One of the things you can ask in retrospect as well is, why don't we just biopsy the spleen and we can figure out for sure, and then we can do the operation with confidence that this is the right thing to do. But as I mentioned earlier, the spleen is an organ that just loves bleeding. Whether you remove half of it or if you biopsy it, all of those are dangerous things to try. So rather than biopsying the spleen to get an answer where, one, you can cause the patient to have this uncontrollable bleed, or two, pierce a tumor that can then start spilling out, the safest thing in this scenario is to try and take it out surgically, which is the right thing we did for this gentleman. So the next transition is just kind of through surgical residency, you have a whole community that grows with you over time. So this is a picture of us from our holiday party, where we have a constellation of head and neck surgeons, plastic surgeons, cardiothoracic surgeons, colorectal surgeons, and surgical oncologists and transplant surgeons all together that are trained under the same umbrella. So we have fun together, we work hard together, And then as part of our training, we have a lot of get-togethers as part of our community of residents. So this is a picture of my wife holding my entry into the surgical residency competition for pumpkin carving in Halloween time. And if you'll believe it, I got third place because someone else made something that was far more anatomically beautiful than a French bulldog to win the whole competition. So we have fun and we work hard as well. So now let me transition for the last, I'm going to do about 5 or 10 minutes about how I got here. So just kind of going through to touch on details related to where you guys may be as part of your training. So I started as an undergraduate at UC Berkeley. I took a year off after I graduated UC Berkeley to work as an EMT, as I'll touch about in a little bit. And then between 2010 to 2015, I was in medical school at UC Irvine. I took a year off between 2013 and 2014 to get a master's in public health in biostatistics at Yale. And then in the year of 2014, I applied for residency and I was accepted at Stanford and I matched there. It's a term we can talk about in the Q&A section if you have questions, to be a surgery resident, where you start off as a junior resident at an academic surgical training program, which means that you have your junior year spent as a consult resident, as a ward or an intern resident. And then after that, you have a period of research that you do that ranges from 1 to 3 years. For my research time, I was very interested in cancer biology. So I went to New York to work at the Memorial Sloan Kettering Hospital, where I was studying genomic markers of tumor biology for 2 years and published on any genomic changes that could be related to how cancers can respond to certain types of chemotherapy or certain approaches where we would use radiation or surgery first rather than chemotherapy. Then I came back and I completed my senior surgical residency years. And then now I'm a Harvard Surgical Oncology Fellow working at the Mass General Hospital, Brigham and Women's, and Dana-Farber. So let me kind of focus where you guys are mostly at about what I did in and around college to get into medical school. So I got a bachelor's in chemistry. And during that time, I kind of think about the things you're supposed to do split into 3 different things that help display and show you and internalize whether medicine is the right track for you. So one is clinical exposure. For me, that was shadowing an orthopedic surgeon that was working in the Kaiser system in California. And after I graduated, I wanted more active experience. So I worked as an EMT. I was involved in research. As a chemistry major, I worked in an organic chemistry lab for 3 years and published literally a single paper on the retrosynthesis of an anti-cancer alkaloid that we had been working on for several years that I was fortunate to be a part of that work for. And then after I graduated, I worked as a research tech on a big clinical trial at UCSF, studying the right number of blood products to give patients that were in trauma scenarios. And that was really where I first realized that I wanted to be a surgeon. And then I categorize this as an other, which is sort of a you factor, what makes you as a person interesting. And for me, I was a teacher, and that was something that kind of was a big flow through for my experience. So very quickly, just kind of how to set yourself up. Clinical, do you know what it means to be a physician? So I think about 3 different varieties of this. You have passive experience. This is kind of what we're doing now, where you're shadowing. There's active experience. You're taking vital signs. You're in the environment where doctors are working. You're helping to write notes and prepare documents for doctors so that way they know the patients that they're going to be seeing in clinic, for example. And then there's also the prior career scenario where you work like I did as an EMT. Maybe you're a surgical tech, as I talked about, or even a nurse before applying into medical school, something that shows you firsthand what the environment is like. Then there's research experience. The main thing is, can you contribute to learn from the science and understand how researchers perform? Because we talk a lot about literature and how those contributions in the past inform what we do now in a medical practice. And so this is a big part of an academic residency training program too, where you're expected to present research like I'm doing on the right-hand picture here. And you have a large cohort of co-residents and faculty that are coming with you to support you in your travel, which is fun because you're going around the country and presenting your research and people are interested in asking questions about it. And, too, you're sort of the expert about it, whatever subject you've been working on by the time you graduate from residency, which is a great feeling to have and an important contribution to the field, especially going forward, if this is what you carve out as what you'd want to continue working on. And this kind of dates back to this ugly picture of me when I was in college working as a chem major in the lab, working up reactions in between classes too. So it starts early. If you're interested in an academic program and you're interested in research, get involved as an undergraduate. And there are a lot of avenues of getting involved through programs at various institutions. And you'd be surprised how often a cold email to a professor that's got a research lab works and gets you involved. And then the other factor can be a variety of things. This can include being a musician, an athlete. As I mentioned, for me, it was as a teacher. And this kind of segues into what I was doing for a little bit of medical school as well, where I worked for Khan Academy, which some of you may be familiar with. It's an online learning platform. So this was a picture back in 2013 when I first met Sal Khan, when a cohort of us were hired to work as medical teaching fellows to develop a curriculum for the new MCAT that had been put out, I think in 2015 now. And they completely had revised the test that I had taken before to get into medical school back in 2007, 2008. And so there was new sociology and psychology sections that you're all probably familiar with now, but did not exist at that time. So I was tasked with creating videos that were part of the physiology and anatomy section. So this is my profile that's still there on their website. And here, if you search my name on their website, here are a couple of my videos that are there, which there's always an interesting story for this, because you'll see that the top were some of these interesting, like, clinical videos, the small intestine, how it works. And then the last videos I worked on were some of the bottom of the barrel videos that no one wanted to pick up and do, which included the entire STD section, which ended up becoming my bread and butter for the end of my time there. But someone had to do the work. I had a lot of fun doing it. And I think a lot of people benefited and learned from it too. So that's kind of how I got myself as an applicant for both medical school and even for residency. People were asking about this experience because it was fairly unique, but it's different for different people. So it really comes down to what you like and what you enjoy. Oh, and this last image is now of a Khan Academy style video that I made in residency. That's now a standard video that we show patients before they're consented to go for this type of an operation known as a Whipple procedure. So if you ever search on YouTube my name and Whipple procedure, you'll find this video that we show at Stanford for patients that are going for this operation. So the last thing of all is just do what makes you unique and what you enjoy. That's what really is going to set you apart. If it makes you happy, you're probably going to do really well at that, and that's really what's going to set you apart. All right, that's my last slide of how to figure out what specialty in medicine you want to go into. So let me just pause there because I feel like I've been talking a lot. I'll take the last 14, 15 minutes for questions.
Well, first of all, thank you so much, Raja, for getting this all together. It was very, very informative. Just going through your cases, the way that you explained it, it was easy to digest, and also it definitely provided a good glimpse into the specialty itself. We always appreciate that. A lot of students love to see cases, so this presentation was much appreciated. Our first question is about the scope of surgical oncology. So you're a fellow, so that's subspecialty, right? You had your residency and then specialized. Could you talk through the cases that, as a surgical oncologist, you would not see because you specialize? I think that's what the student is referring to. But by the way, if you'd like to clarify that question, feel free and we can go through it. I believe that's what they're referring to by scope.
Sure. I think I understand the gist of the question. So it varies based on where you're training as well. So surgical oncology is a very broad subject or field. Technically, the program I'm in is called the Complex General Surgical Oncology Fellowship, which means we primarily focus on abdominal surgery, abdominal cancers, but we also do things like melanoma or sarcoma, which are types of connective tissue or skin-related cancers that can really occur anywhere. So I've taken melanomas off of people's forehead, the back of their head, their neck, their feet, their arms. I've removed sarcomas or connective tissue cancers that are in their arms and legs, but also in their abdomen. But the reason I applied into this program in particular is I'm mostly interested in abdominal cancer. And my particular love is in liver, pancreas, bile duct, and gastric cancer, which is what the program I'm in currently is very strong at. There are certain other programs around the country that are also complex general surgical oncology or CGSO that have a stronger focus on sarcoma or more extremity types of cancer, or can also include a larger component of liver and pancreas training, which does not cancer, but benign liver cases. And that also includes transplant. So you can have the same role that I have, but work somewhere like at Memorial Sloan Kettering, where they have 7 fellows per year. And one of them is designated as the liver and pancreas fellow, that in addition to doing exactly what I'm doing here at Harvard, they additionally will get a month of transplant surgery. So you do liver transplant, you do kidney transplant. You get the experience of technically how to do those operations. And most importantly, how do you manage them thereafter with immunosuppressants? So to answer your question, surgical oncology has a large breadth. Different programs have different focuses, but we are not doing things like brain cancer. I'm not doing any neurosurgery whatsoever. I'm doing some occasional like head and neck surgery. I mentioned melanoma. I'll do thyroids as well as part of my training. And I have the option of doing that in my practice as well. And I'm generally not doing pediatric surgery, but there are rare circumstances where a pediatric hospital and their surgeons do not feel comfortable doing a big cancer operation. And so they come over to the adult hospital and we would do that as well. But generally, I'm not operating on folks younger than like 16 or 17 years old.
Mm-hmm. And that actually answers our next question from the same student about the pathology, how it's divided, if surgical oncologists will cover things like breast, thyroid, colorectal, etc. So to move on past that question, our next student asks, regarding your research experience as a student, what makes your experience different from another medical student who, let's say, doesn't have an MPH or has an MD PhD instead?
That's a good question. And I'll just kind of to give like the last point for your last question, I also do breast surgery as part of my training as well. That's considered part of the CGSO training. So for research, at the end of the day, it comes down to what you enjoy and who are your faculty mentors wherever you're at. So that has to really line up. It's very difficult when you have a faculty mentor you like, but it's not working on something you enjoy. It's also very difficult if it's something you like, but no one is really there to help champion you. That said, there are cases in both scenarios where you can make it work and you fall in love with something that they're doing that you didn't think you would, or you are fortunate enough to find supporters of something that you do not have support for, but when you got there, that you can really take off and do well with. But in terms of what I'm able to do with my MPH, the main reason I got my degree was so I wanted experience doing my own biostatistical analysis. And so I learned mainly the nitty gritty of how to code with SAS at the time when I was doing my MPH at Yale. Now I use primarily R because there's a lot more online support for that, and many of you may be familiar with R. But I still code with SAS occasionally. But that was an opportunity to develop a library of code that I can use when I'm trying to do my own outcomes analysis for basic statistical questions. And I think that's also applied as well for basic science work, which includes like wet lab, chemistry reactions, mice models as well, where you're trying to look at a statistically significant difference between a drug used in one mouse versus another on a series of mice. If you use the same statistical training that I had, can be employed in those scenarios. Now, to answer your question otherwise, if I didn't have an MPH and I just went straight through, you probably could still learn how to do your own biostatistical analysis. You just don't have the opportunity to have that mentorship to really guide you in the right direction. You don't have the environment to learn as well, because in addition to getting my MPH in biostatistics, I also was very involved in the bioengineering school. And during that time, I actually got a patent on a device that allows circulation to go to small bowel that's been removed from the body as part of a project where you can pilot drug testing in the bowel or preserve bowel for a bowel transplant in patients. And we were able to publish on that and present on that as well. And that wouldn't have been possible if I didn't have that time to set aside from medical school to do something separately, where I was getting my MPH, working in the bioengineering school. And I even took some classes at the Yale Law School as well around the same time the Affordable Care Act came out. So that was the other advantage. Now, you do an MD PhD, you take that up to 100. You have dedicated time just to research. This is generally, my wife has a PhD and she did it in bioengineering, and she did her training in about 5 years. And that's kind of the average, I think, for PhD. Some people will do it in 3 years. Some people will do it in 5 years. And this is really dedicated time where, as I mentioned, you become an expert in your field. The papers that are cited in the future on the topic you worked on are the ones that you published as the first author. And that generally going forward is a very strong feature in a candidate that's applying for academic institutions. So let's say if I have the same board scores, number of papers, and quality of letters of recommendation when I'm applying to a residency program, and I'm an MD MPH, and I'm going up against a similar MD PhD versus a similar MD candidate, the MD PhD is going to be picked because they have the greatest likelihood of being productive in research if they are applying into an academic research institution like Stanford. But it really depends, because you can still be very successful without a PhD, with an MPH, or without either as just an MD alone. It really depends on the support that you get.
Those are some great points that you do raise. Our next question asks, could you expand a little more on what drew you to specifically oncology in particular for your fellowship?
That's a good question. So when I came into residency, I really thought that I would do trauma. I really enjoyed working as part of as a research tech at UCSF on a trauma clinical trial. That's what I thought I would do. Then I realized as a surgery resident, trauma most commonly is not operative. You end up having an elective practice where you're fixing hernias, you're taking gallbladders out, which are great operations, lots of fun. You make a huge impact for patients, but you don't generally have long-term longitudinal relationships with people to see how they do. That's, the extreme version of that is pediatric surgery. You take care of a child that's just after they're born, you get greeting cards from their families for like the rest of their life or something like that, which is just so lovely and rewarding. But for me, surgical oncology was the opportunity to have complex cases where you're operating very frequently. You're in the abdomen and you've got known anatomy. So you're not going all over the body and having to learn extremity anatomy, anatomy of nerves that are superficially on the face as well, that you could, be not the expert, but somewhat experienced at, and then still have a fear of damaging. I wanted to be working in one space in the abdomen. I wanted to have a longitudinal relationship with patients, and just the research and the biology of cancer was really fascinating to me. And I think the last point I'll mention is when you're looking for a career, you don't want to think about the career as it will be in 2023, because that's not going to be your job. You're training to get to that job in the future. So I'm in my last year of training now. And when I decided I wanted to be a surgical oncologist back in 2015, immunotherapy was not standard of care for patients. Pancreatic cancer was like the fourth most common cause of cancer death. Now it's number 3. And so the landscape of what we do over time changes. And rather than being in a field like trauma, where there isn't much change in how we can improve patients' life that can happen in a common scenario with something that happens to a lot of people. Like, not everyone gets into a traumatic accident, but a lot of people end up getting cancer. You can make a huge impact for somebody if you're in a field like oncology, where there are rapid changes in how we treat people, that over the course of my small career so far as a fellow, that there's been a huge shift in how we treat people with melanoma, where we rely on immunotherapy rather than just removing some metastatic lesions. So I'd rather be part of the change rather than see it in the rearview mirror from like another field.
Our next question is about staying motivated through the long journey. I know that starting off at UC Berkeley, I know it's definitely a tough school with a lot of courses that challenge your GPA for sure. So, I mean, starting off with that and then going on to med school residency, it's a long process and it's a challenging one. For you, what kept you motivated?
I think it's short-term, intermediate term, and then long-term goals. You can't focus on the long-term goal all the time, because you'll always feel like, what am I doing in my day-to-day? Like, why am I doing this? What am I doing that? Setting small sort of field goals to make along the way makes it more rewarding on a day-to-day basis. And plus, the people you're with as you're training, like the joy of learning, the joy of contributing to the field as well, have to be the things that fulfill you. I think that's also sometimes can be a red flag if you're not enjoying the community that you're with, you're not enjoying the material that you're learning or the research that you're doing and contributing to. You got to ask yourself if this is something that you're going to enjoy doing in the long term as well. So I would say, if the task is how do you keep yourself motivated, you got to keep your goals sort of boxed in those 3 different varieties I mentioned, but focus on the ones closest to you now that you can achieve, so you can have like that dopamine rush, that satisfaction of getting it done now, rather than focusing on the long-term thing that seems totally not feasible because it's 10 years down the line.
100%. It's just not realistic to be focusing on those long-term goals when they're years in the making. Another thing is, and you mentioned this earlier, you joined in or you had a passion as a teacher, which you cultivated through experiences like the one that you had at Khan Academy. How do you plan to continue further developing that going into your years as an attending?
Well, the fortune of being an attending as well is that you're always not just a teacher, but you're also a learner. So if I'm fortunate, I will, after finishing fellowship, have a job where I'm working at an academic hospital, which means that I'm training not only residents, but I'm training medical students as well. So I'm teaching them in a different way than I taught when I was a chemistry instructor in college, and definitely a very different way than when I was a medical teaching fellow for Khan Academy. When you're an attending, or even now as a fellow, I do the same thing, that when I'm trying to teach residents through operations, like what I just mentioned about the short-term and long-term goals, I asked them to focus on what is a specific thing about this operation you want to achieve today. If we're taking a gallbladder off, tell me what are the 4 specific steps of this operation and which step you want to focus on today, because I want to make sure we do that perfectly for you. And then when we do this operation again, the next 3 times, we're going to achieve the next couple of steps. So teaching is very different at different levels. And the joy of it is you get to see someone that started off as an intern that was afraid to hold the camera or afraid to hold a laparoscopic instrument, in 5 years, expertly taking out the gallbladder with very minimal assistance that I'm providing them. I think that in its own self is its own dopamine rush that's very tough to duplicate in a lot of other fields.
100%. Well, maybe we can end on one more question just before we wrap up. And at the end, by the way, I will have a few reminders at the very end about our quiz. So I'll just have a few things to say after the questions. But the last question is, how did you go about finding summer opportunities specifically for research? this student is just wondering how they can make use of their summer outside of just volunteering at a hospital to go out and do further activities.
Yeah, I mean, I harken back to the slide where I was talking about the other opportunities that you can have that get you really exposure into the field, especially if you're looking for clinical experience. Sometimes it's tough with volunteering, especially in the pandemic era, and you really have to just try and find an opportunity where you're instrumental to the workflow. So, for example, at MGH and primarily at the Mass General Hospital, actually, we have undergrads that are from nearby institutions that help prepare notes for clinic patients, so you can work as a scribe. And often there are programs like that that are available. You just have to find emails for these faculty members and ask them if there's an opportunity for you to get clinical exposure helping as a scribe or shadowing in the operating room to see. But then again, that's passive experience, which is great, just like this. But if your interest is to do something more active, often that's going to involve some additional training. Like if you become an EMT, I had actually a 2-week course that helped train me to become an EMT, and I was ready to go during one of my winter breaks in college. And that's what I did for most of the beginning period of my year off between college and medical school. If you're interested in research, a lot of institutions, a lot of colleges have programs that you can apply into, but you'd be surprised if you just cold email a lot of faculty or lab PIs, they will have projects or they will have opportunities for you to get some exposure. And you just have to figure out what kind of research experience you're looking for. If you want to be in the lab and you want to do wet lab training, that's going to be a long-term experience like what I had done in college, and you're signing yourself up for a year, 2 years, 3 years of work, which is fulfilling and great. And you become part of a lab community that loves supporting you and watching you grow as you help towards a central project. But you can also work with a medical faculty member on a small project, like a one-off outcomes project as well, to help collect clinical data from the chart and answer a question, learning how to use your own statistics to address that. So it just has to depend on what sort of exposure you want. And my recommendation is try to get a little bit of each to figure out what you want to do. And while you're an undergraduate, that's really a keen opportunity for you to get some basic science experience, because that's really your time and your opportunity to get involved with a lab community that can really mentor you forward.
Yeah, well, I think that's some great advice to wrap up our session on. Like I said, just a quick few reminders for those who are listening to our shadowers. If you'd like to earn credit for your attendance, we have a quiz, and that quiz is posted in the chat box. It's also on our website. Either place is going to lead you to the same link, and that's a Google form, 10 questions. If you have 6 or more of them correct, you will pass, and you'll also receive your certificate. That certificate will be sent to the email address that you list. I'd recommend that you include a personal Gmail or Yahoo email, just so that it doesn't filter out to spam. And just in case you don't get it to your inbox, please do check your spam folder, just in case. If you don't receive it in either folder, please do feel free to email us. Again, our email is shadowing.h@gmail.com. And that quiz will be due this Sunday, May 7th at 11:59 p.m. Central Standard Time. If there's any questions that y'all have about our other programs, about shadowing in general, we always are happy to take them in case I didn't cover any questions that you might have. And then one last thing is our next session, the last one that we'll have for this spring, will be later this Thursday on May 4th with Miss Melvin. She's a practicing PA in OB-GYN. She's been practicing for over 10 years. And we're going to be seeing her again, 7 p.m. Central on Thursday, May 4th. Follow us on Instagram, join our listserv if you'd like to hear more. We will be continuing in the summer. And just as we've had over this past spring, we expect to have physicians, PAs, other professionals joining us in, because I do know that we have some pre-PAs joining us in, some pre-dental students joining us in. So we have speakers for all of y'all. Again, feel free to reach out with any questions. If we could have a few thank yous in the chat for Raja getting this presentation together. He took the time to go through it and explain these pretty intricate cases to us. A great teacher, I have to say. So thank you so much. Thank you for getting those MCAT videos. I've been actually watching a couple of them. I recognize your name, so I think we have more than one thing to thank you for, but we really do appreciate you taking the time to join us today, Raja.
Pleasure to be here. Thanks so much for inviting me.
All right. Hope everyone enjoys the rest of your week, and we'll see you on Thursday. Take care.